Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining today's Policy Spotlight. Policy Spotlight is a series of virtual events Health Affairs launched in 2021. They feature in-depth conversations with influential health policy experts. Previous Spotlight events have features people such as CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf. Most recently, I spoke with Nora Volkoff, the Director of the National Institute on Drug Abuse at the NIH. If you missed these or any other events, they are always recorded and they can always be accessed on our website. Today, I have the pleasure of bringing to you Micky Tripathi, the National Coordinator for Health Information Technology within the U.S. Department of Health and Human Services. The Office of the National Coordinator, or ONC, leads the federal government's health IT efforts. The position of National Coordinator was created in 2004. The division has a mission to create systemic improvements in health and care through the access, exchange, and use of data. Now, Micky was actually an early guest on Policy Spotlight. I had a family emergency and was called away, so I did not get to be the moderator for that. It's my pleasure to be able to now have an opportunity to talk with him. If you're watching us live, I do want to note that you have the opportunity to drop questions in the Q&A tab at the bottom of your screen. I'll do my best to weave those into the conversation. It helps if they're of general interest, if they're brief, if they come in early. I'll do my best to get the audience's topics of interest into the discussion as we go forward. With that, it's my pleasure to introduce to you Micky Tripathi. Dr. Tripathi, as I noted, is the National Coordinator for Health Information Technology. He has more than 20 years of experience in health IT. He was the Chief Alliance Officer for Arcadia and Argonaut Project Manager. He's had positions at the Massachusetts eHealth Collaborative, the Indiana Health Information Exchange, the Berkman Klein Center for Internet and Society at Harvard University. He holds a PhD in political science from the Massachusetts Institute of Technology, MIT, master's in public policy from Harvard University. Nice to have another Harvard MPP on the show, along with me, and a bachelor's in political science from Vassar College. Dr. Tripathi, thank you so much for joining us. It's great to, as I say, have an opportunity for me to moderate a discussion with you and not just listening to a recording that someone else led.
Great. Thanks so much. Really delighted to be here. And Micky,
yeah, we love these opportunities, and I always like to just open with a very broad question. It's nice. We'll cover a lot of ground, but I always like to hear from my guest. You've been in the role for a little while. Tell me what you view as your current top priorities, and we'll, I know, discuss some of them, but it's nice to hear them from you.
Sure. So we are, focused on, sort of taking the best advantage of all of the work that we've done over the past decade in getting health IT systems into place. We've spent, more than a decade, a tremendous amount of money on the public side and in the private side. A tremendous amount of sweat equity on the part of provider organizations implementing electronic health records, as well as developers and others getting those into place. And now, one of the great things about taking this job at this time is that the dust has kind of settled on a whole bunch of that. And so now, I've had the opportunity and the privilege to be able to, start to work with the team to say, what are the things that we want to be able to get out of these systems? And that's what we've been focused on. So interoperability, we'll certainly dive into FHIR APIs and TEFCA, data standards, doing everything we can to get more and more of kind of a standard minimum data set to be able to allow people to exchange information and be able to use that information in meaningful ways. And increasingly thinking hard about the uses of that data once you've allowed it, once you've made it flow better and better. So you've got interoperability, you've got information flowing, and then you start asking the questions, well, what is the responsible use of that information on the other end? So it certainly focuses on health equity and thinking about the different dimensions of health equity. And one part of that is related to AI and AI-enabled tools, which is on everyone's mind. And ONC has issued a set of regulations in December related to that as well. So a lot of things on the plate.
There sure are. So I like how you describe that as sort of building the infrastructure and then trying to capitalize on its use. It's those who are at the front are definitely looking at how to capitalize, and I want to talk to you about that. But I do have to say, and we publish plenty here at Health Affairs, there are lots of people who would say the infrastructure isn't really quite where it needs to be around interoperability, around data availability, around ease of use. We certainly, continue to hear clinicians describe the challenges associated with just adjusting to a world of heavy reliance on electronic health records. So before we get into sort of the fun, exciting use cases, can you give me a sense of how finished you think we are with, or how steady a state you think we really are in with respect to the infrastructure, or what the remaining priorities are so that we can focus more on the use case side of this?
Sure. Yeah, and I certainly don't want to suggest that that there aren't issues with things like usability and things like sort of data availability and having the information available to you when you want it. All of those things are real issues for sure. But I think we also just need to recognize that that over a 10-year period, we went from a point of having something like 5 or 10% of providers using electronic health records to where we are now, and that's 97% of hospitals and about 80% of ambulatory providers using certified electronic health record systems. And and everyone's got issues with with the technology in front of them. You talk to many people who are very, very happy with the systems they have. A number of them, large fraction, probably the largest fraction, who are not always happy with them, but say that they would never go back. And then, of course, you've got those folks who are like, the day that the EHR system is down is the happiest day of my week because we go back to paper. So, there is that whole spectrum for sure. What we're trying to do is try to open up the EHR systems so that they have more of the platform-like capabilities that I think is a key to that sort of usability that that all of us are striving for. And what I mean by that is, you think about the way your cell phone works. If any of us were locked into what Google, this is an iPhone. This is provided to me by the federal government, so it's an iPhone. But if any of us were locked into only what Apple provided or only what Google provided on an Android device, we'd feel frustrated, right? We'd feel locked in. We'd feel like, wow, I don't have the kinds of things that I'd like to be able to do. But we have the opportunity to now, on these devices, which are more open platforms using API-based technology, to download apps. And so you and I may have the same version of an iPhone, but our experience and our iPhones actually are really different because we've downloaded a set of apps that's unique to the kinds of things we want them to be able to do, and it's really easy. So ONC regulations have pushed EHR vendors to do the same thing, which is to say they are required as of December 31st, 2022, to have these open APIs. Open not meaning not that they're not secure, but open meaning based on an open industry standard, not a proprietary standard. So again, that was just over a year ago that they were all required to do that. And so I think, and we very much hope, and we're pushing very hard to say that going forward, what that'll enable is that kind of experience that I'll be able to download a set of apps and be able to use those apps that meet my needs as a user and make this all a little bit more convenient, a little bit more tailored to my experience, and hopefully make people feel that they're able to customize it in ways that get them over some of the barriers that they feel right now. I think the other thing for us to recognize is that a whole bunch of, at least we've done a bunch of work on burden reduction, and we continue to working with our partners at CMS and, part of what we've done with our advisory committee and with others. And one of the things that always comes through is that the challenges that people face with electronic health records, or what they say is about the electronic health record, ends up being not the electronic health record itself. It's that the electronic health record magnifies issues with our healthcare system at large, right? So things like documenting to support claims, for example, and billing, quality measures, more and more quality measures that have more and more data requirements, prior auth. Don't even get us started on prior auth, right? All of those things, which aren't about the electronic health record, they're about things that are being forced through the electronic health record, and that people experience as that's a huge burden. It's because of that EHR system. It's like, well, no, it's really about the fact that the EHR system is just sort of making more transparent some of the inefficiencies and and in many ways some of the flaws of our healthcare delivery system overall.
Well, I can certainly appreciate both sides of this, that there is both work to be done to build this into workflow, and that in any data project, you do amplify the pre-existing flaws and surface them, and it is easy to attribute flaws from other parts of the system to whatever happens to be in front of you. You mentioned the APIs. You wrote a piece for us a few months ago on TEFCA. I'm going to assume that people who are drawn to a conversation like this have a basic understanding of what that's about, but I want to make sure we sort of bring everyone along. So, given your earlier comment about focusing on use and usability and how it opens the door to improvements, talk to me about the opportunities that TEFCA unlocks, what you feel you've accomplished, and what the road is ahead.
Sure. So TEFCA stands for the Trusted Exchange Framework and Common Agreement. You don't need to remember that.
Good.
Who knows what CVS stands for? Who knows what HBO stands for? We know what they are. That's kind of the way to think about TEFCA. But TEFCA is nationwide network interoperability, or network to network interoperability is kind of more specific, and it was direction that came from the 21st Century Cures Act that was passed in 2016, so a long time ago. But we have worked very hard since we came in just over 3 years ago. I came in on day one of this administration, and we've worked very hard to put that in place. Because we see it as sort of the opportunity for us to get to that next level of interoperability that all of us really want to be able to achieve. And the ultimate success, I would argue, is when people stop thinking about interoperability, that it just works behind the scenes. And what would be a good analogy? Cell phones. Think about the way cell phones work today. There's AT&T, Verizon, T-Mobile, Sprint. Most people don't really think about the fact that those are actually different networks. They are proprietary networks, each of them different companies, and each of them have their own flavors within their networks. Yet when we purchase a phone, we never for a moment, worry that, oh, Alan's on Verizon, I'm on AT&T. Maybe we won't be able to talk to each other, right? Because our user experience is that it's a single network. It's connected on the back end. That was actually a fair amount of work that was required to some very selective, federal regulation, some agreement on open industry technical standards, sort of business, sort of arrangements across those networks. Combination of those things that gives us all the experience of just pick a phone, pick the phone that best suits you. And that'll be on a network, and that network will be connected to everything else. ATM networks work that way as well. For those who are old enough to remember when you had to look at your card and think, oh, this is a Cirrus card. I need to call the bank and figure out where there's another Cirrus ATM machine, right? It's kind of unthinkable now, but we never think about that. It's all in the background now. Again, we can go on and on. Banks, ACH networks behind the scenes that make sure that when I do a transaction using Venmo, that it gets reconciled, and I never worry about whether that's going to get reconciled. So all of those things are sort of examples of network to network interoperability that operates the behind the scenes to make sure that information is available where it needs to be without the user worrying about it. And that was the direction that we got from the 21st Century Cures Act. So TEFCA, and there was the recognition that there are dozens, if not hundreds of clinical interoperability networks that already exist in the market today. Some of them are state and local networks. Some of them are, a number of them are nationwide networks that aren't really connected. I mean, some of the nationwide networks have done a great job to connect themselves. It's not perfect, but that work has has been established for some of those networks. But it certainly doesn't create that experience of I joined my state network that means I'm just in my state network. Now I have to figure out, what other networks do I need to join to be able to, sort of have that interoperability experience that would, sort of give us that same experience like cell phones. So that's what TEFCA is designed to do, is to say, let's have a common model across the country that has a single user agreement, so that we're not worrying about that provider organization in Nome, Alaska. Now they're requesting information from me, and I'm in Sarasota, Florida, or in Boston, Mass. How do I know who they are? How do I know whether they're authorized? How do I know whether this is secure? All of those things. How do I know that they're playing by the same rules of the road? We've signed the same common agreement when you're in TEFCA, regardless of which network you're in. So you have that assurance and that experience, and you have the expectation that they are actually going to respond with a data package, a data set, a minimum data set that will give you basic information to allow you to do whatever you need to do. Won't solve all interoperability problems. The idea is that let's just create a universal floor so that everyone, regardless of which system they are on, regardless of where they are in the country, they can have that expectation. They can just have that system connected, and they can get basic information, from any other system. And if they need more information, then they would have to do it, sort of the old-fashioned way. But I think we all have that experience, right? I mean, in our lives, we often have to do deep dives to be able to get, more richer information, or information more unique to our circumstance. So that's what TEFCA is that nationwide network that connects up all of those networks that have existed in the market today. One of the things I would just point out is that this isn't unique to healthcare at all. If you look at like the history of telephone networks, at the turn of the last century, there were thousands of phone networks in the US, literally thousands of them. And connecting them up was a huge challenge, and people didn't know how that was going to work. And over a number of years, you had consolidation, you had agreements among phone networks, you had government regulation that brought them together. I would submit that that's kind of where we are today. It's sort of the early part of network interoperability. Now that everyone has EHRs, and now we have sort of the push to say, let's take the lessons learned from those other industries and fast track the ability for us to have a nationwide network interoperability that all of us have been waiting for over a dozen years, for sure.
I'll add to your alignment metaphors the subway system in New York, which of course has different lettering and numbering because they were actually different companies competing against each other. Right. And now it's sort of unimaginable that you would have competing subway lines.
Right. I actually didn't know that. I have to look into that.
So
into interoperability rabbit holes. So
yeah, I hope I'm right on that. I'm fairly confident that's not an urban myth. But so this is great as a vision, and what I'd like to do is really spend some time on the use case side of this. Why should we be excited? What are you hearing? What are you promoting? What are you encouraging? And I have a few different lines of inquiry. Let's start with one tied to a forefront piece that we're publishing today that you co-authored with Marco Mijic at the California Human Services Agency, talking about the tie between health and human services data. And actually the very first question that came in from the audience was about this. So I think I know we've hit an important topic here. There's so much discussion within healthcare about the need to address the so-called social determinants. Much of the information about people's circumstances does not currently reside in the health sector, although there are efforts to add data there. But certainly the service side is generally not provided by healthcare providers. So I'd love to hear sort of where you think this is going, what you think the opportunities are, what you view as some of the barriers, and I have a few of my own that I'd like to ask about. But talk about this as a use case.
Sure. So there are, certainly areas that that we haven't gotten to with respect to interoperability, and human services is one of them. And we remind ourselves often in the department that we are the Department of Health and Human Services. We got both those sides. So we've done a lot of work on the healthcare side, and we're now starting to turn to human services. There is a lot of work to do there in the to get human services adopting open industry standards, the kinds of things that that we've been doing on the healthcare side for a number of years. There are also a whole different set of rules related to the sharing of information, as we know. I mean, HIPAA is sort of a defining a set of regulations that allows us to share information under certain conditions and among certain parties, that has enabled scalability of these nationwide networks. So TEFCA, for example, is very much is based on applicable law, where HIPAA is the applicable law across all jurisdictions. And then, of course, you have on top of that whatever is sort of a state law that would exist on top of that. But that provides a little bit of a unifying force, because if you're exchanging information for treatment, payment, or operations, as I think is well known, you aren't required to get patient authorization as long as you're doing it among HIPAA entities, HIPAA authorized entities, and you're doing it for treatment, payment, and operations. It turns out that allows a lot of interoperability to happen. And so those first set of use cases, or the exchange purposes, as we call them in TEFCA, are all based on the premise that it would be based on treatment, payment, and operations, because you're going to do it among HIPAA-regulated entities, and that gives a certain degree of assurance to the other parties that, all right, everyone I'm sharing this information with, not only are they bound by this common agreement contract, but the vast majority of them are also covered by HIPAA. So I know what the rules are. I understand, that they have to live with that I have to live with that, and that gives, sort of a good foundation for it. The challenge with human services is most of those entities are not covered by HIPAA and those kinds of, those kinds of exchanges. So from a TEFCA perspective, we started with things that would fall under treatment, payment, and operations, and that's sort of the first layer and the first level of what we're doing. In working with California, what we've done is said the California Data Exchange Framework is a great and very ambitious set of initiatives that looks at clinical interoperability, but they want human services interoperability as well. And so in working with them, what we've sort of aligned around is to say, use TEFCA and the TEFCA infrastructure and the federal pipes, as it were, to solve your local needs as it relates to clinical interoperability, and then build on top of that to service your state-specific requirements related to human services. So it's very much that they can add on to that, say we've got a foundation in TEFCA that allows us to basically say that clinical interoperability needs within the state of California will direct organizations in California to use TEFCA to service those needs. And then they're building additional capabilities and additional infrastructure, both policy and technical, on top of that to serve the human services interoperability that they want to be able to sort of advance in California. I think from a federal perspective, we see that as a great laboratory and almost like a leading edge innovator to say, that's fantastic. California can move ahead with that. That'll offer lessons learned to all of us as once we get the clinical interoperability, sort of framework in place and really up and running, it'll allow us then to take some real lessons learned from an advanced and and very complex state, to be able to say what are those lessons learned that allow us to apply that more broadly across the ecosystem nationwide. One other thing I want to touch on for a second, though, is the data, because certainly a part of that is supporting the data elements that are important to human services and human services organization that are in the broad category of what we call social determinants of health. And ONC, we also, a part of what we do is we promulgate or approve data standards that we call the US CDI, the US Core Data for Interoperability. And those are kind of a foundation, almost the minimum data set of the healthcare delivery system, I would argue, because they're required to be supported by all certified electronic health record systems, which again, cover now are used by 97% of hospitals, 80% of ambulatory providers, and more programs like federal agency programs draw on the US CDI. So quality measures, for example, increasingly draw on the expectation that you're going to have the US CDI data elements to allow you to calculate quality measures, for example, that you're required for, to report to CMS, for example. We're working very hard with CDC to establish public health data models based on the US CDI. So that increasingly is kind of a foundation. The reason that I mentioned that is we've added in the latest versions of the US CDI more and more elements related to social determinants of health. So our expectation would be that we add more and more of those data elements because we know that they're being captured and are important. And as we think about the policy overlay in TEFCA to allow exchange of information with human services organization, you'll know that you have the data foundation to be able to support that. So it's very much working on the different pieces, but that's how they all come together ultimately.
So you've jumped about 3 steps ahead of me, which is wonderful. But I'm now scrambling.
I'm excited about this stuff.
Please don't apologize. I'm just trying to catch up. I mean, this brings to me, I guess I'm sort of again at a much more basic level, which is when I think about the early years of ONC and the investment, it was, as you say, you went from very low rates to 97%, 80% of having these electronic health records. Even the existence of that technology infrastructure is rare in the social services, human services world.
Yep.
So you've got sort of these standards and all of these data elements, but you don't have a computer, right? Or you don't have you have a low speed internet connection. You certainly don't have ICD codes and all of the other kinds of standardization that's occurred within healthcare, because it's a fifth, a sixth, a fifth of the economy. And so I guess so. Let me just step way back, if you'll step back with me,
Mhm.
and hear you saying that California is an experiment. There'll be lessons, and that's great. Um, is there a comparable sort of basic infrastructure agenda around the human services data elements akin to what we had, 15, 20 years ago with respect to the health infrastructure? Or is that something that you're leaving that to California and do what you want to do? We're just here on standards.
No, so we are within the department. One of the things that we've been working on at the HHS level is having ONC start to focus on human services data as well. So we focused on clinical interoperability and clinical data elements, and we are now going to put under our umbrella human services data elements as well. So that's the first part, is that we're going to now start working with our HHS agency partners who are in human services to start to standardize more and more of those data elements that will allow greater standardization, greater scalability, and better integration of human services and healthcare. I mean, that's a long process, right? That doesn't happen overnight, but that's, under this administration, we've, sort of focused on that, and, and the HHS leadership is, very much supporting that for us to be able to start to do that. So I think there'll be more announcements to come on that, but that's, that's a focus area of ours for sure, coming very soon. That doesn't solve the problem that you were describing, which is, well, if they don't have technology, they don't have technology. And if they don't have the money to purchase technology, they're not going to have technology. That's a big issue for sure. One of the things that I think that will hopefully mitigate or help with, overcoming that barrier is that, the move to more modern conventions for interoperability, namely FHIR APIs. And, for those, again, who don't know what a FHIR API is, you don't need to know the technical things. I would just, just think of it as app-based interoperability like you do every single day on your phone. And that's really what it's about, is that kind of easy capability. And requiring that those EHR systems support that type of integration and interoperability, I think opens up the opportunity for us to say, well, human services organizations, they don't need a full-blown, Athena Health electronic health record, right? That is not a technology that's appropriate to their needs. They're, now here we are, thinking about developing things from the ground up, or the opportunities to say they can have much more nimble, agile web type of applications, which are much smaller footprint and easier to develop and much cheaper, but would allow them to have the capabilities to integrate with healthcare delivery systems, for example, because of the use of these more modern, very lightweight interoperability mechanisms that are, widely used across the entire internet economy and are only now coming to healthcare. I mean, it's, healthcare has finally discovered the internet. So I think that should give us promise and, and hope that, that those organizations don't have to have the big lift of $65,000 per user, or whatever the price is for an EHR. There is the opportunity for a lot more innovation and lightweight technologies, and allows them to step into it. Right, you don't have to purchase a total full stack system. You can purchase components which are really relatively easy to develop. I'm relatively. I mean, it's not free, but and I think that there are lots of human services organizations who have those capabilities, and this gives them a pathway for being able to make more targeted investments to be able to do that.
So I think what I'm hearing you say is that standardization and better data flow creates a foundation that makes entry into the world of digitization and electronic information. The barriers to entry are lower. And so as human services, which has made much less investment in this as a whole, I don't want to single out anyone, but But as a whole, it's made less of an investment in this in healthcare. That one of the benefits of standardization is that you lower the barriers of entry to having that kind of information in these places that don't have as much, and we don't know where that will go, but hopefully it's a more efficient entry than what we had to do 15 years ago of literally buying PCs to put on desks in doctors' offices. I think we did that, didn't we?
Oh yeah, we did.
That's what I thought. Okay, so we're
I
probably not
myself, I
doing that.
myself worked on a lot of that. Yeah, no, I think that's exactly right. It's certainly democratizing, right? It lowers the bar, and allows more opportunity for innovation, by having more open industry standards that we can drive across the industry. It creates a market opportunity. Right now, if you know any vendors who are in that space are in highly custom world, right? What they build for one
Right.
human services
Right.
organization isn't something they can sell, and so the economics of it just don't work. So that's a whole part of this, is to say that if you have this set of open industry standards and you can drive what we think of as an open architecture ecosystem, that creates the opportunity for innovation, because innovators see the opportunity for investing in solutions that they can sell over and over again, and that gives them markets, and that drives more of that innovation. By the way, we're doing the same thing with public health. So we've been working very hard with CDC and the public health community to drive the same type of thing, to have integration based on open industry standards, so that public health jurisdictions aren't in the box or the bind that they're in today, where each jurisdiction, if you go into any public health jurisdiction, each one is very different than the next one, even in the neighboring state, because they've developed all sorts of custom stuff. And want to be able to say, why don't we base all of this on open industry standards that'll create more of a market for more commercial off-the-shelf solutions, and it will assure you of integration with the healthcare delivery system, which is something that both public health and the healthcare delivery system desperately need.
Okay, so that again, I love the positive story, and I appreciate the opening up of new markets, but I guess I want to take the other side of this, and actually a question came in that's similar to one that I would have had, so I'll try to weave them together.
Sure.
And I'll make this sort of a big question, let you come at it however you want. From a user perspective, from a building apps perspective, all of this information exchange stuff is great. But there are lots of forces in healthcare right now which make data hoarding financially valuable. Having data that your competitors don't have lets you build clinical pathways. It lets you, we'll talk probably, I'm sure, about artificial intelligence, but what are the inputs into AI? They're forms of data, types of data. We have payment models where a health system wants to keep its patients in the system, because if they leak outside of the system, they risk getting care that they're financially liable for that they didn't control. And the best way to keep it, well, there are lots of ways to keep your patients, but one great way to do it is to make it hard for them to get the information they would need if they wanted to go elsewhere. And then, of course, we have all this consolidation in every part of healthcare, including on the technology side. And so I'm trying to understand. I mean, again, I think I get from a technology perspective the possibilities of interoperability. I get the regulatory side of requiring it, but is that strong enough to counter some very strong business imperatives to sort of follow the rules enough to be a rule follower, but find ways to work against them so that you have a business advantage in another aspect of healthcare?
Yep. Yeah, no, it's a great question. It's a real issues. Obviously, couple of things I would note. One is that there's actually more interoperability happening than people appreciate. And some of the challenge that we have is that it's not fully implemented by the organizations who are actually using the technologies. So case in point, there is a nationwide network called Care Equality, and TEFCA would be sort of the next evolution of that in some ways. Care Equality connects up some networks. They manage something like 30 to 40 million transactions per day of medical record exchange between different EHR systems, between different provider organizations. 30 to 40 million per day. I would just note that the SWIFT Global Banking Network does 41 million transactions per day across the world, right? So that's a tremendous amount of interoperability that's actually happening Now, why don't most people know that? And why don't most people experience that? Well, I'll just give an example of, of experience I had personally. My mother broke her hip, went to a acute care hospital, here in Massachusetts. They were on a very, very well-known and well-regarded EHR system. And then we were going to transfer her to a rehab hospital after that, right down the road, less than a mile away. They exchange 10 million patients, a day. They're also on a very well-regarded, high capability EHR system, and those systems are connected up on the back end through the network I was just describing. Yet, when my mother was being discharged, what did they do? They turned to me with a stack of paper and said, "Here is the electronic health record, or here's her medical record. Please bring it to the other place, and they will scan it up."
Scan it.
And I was looking at them, and it's like, you're doing this right in front of me. No shame.
Do you know who I am?
Right. Well, the thing I just wanted to know, and it's like, I'm going to take care of my mother right now. I'm not going to argue with you. But the thing I want to note is that the interoperability is there, and this isn't blaming the frontline people. This is not their fault, right? But their organization has not taken the time, the effort to push that interoperability all the way down, so that it's easier for that frontline worker to say, "I'm going to do this electronically," than print it off and hand it to the person, right? Their organization instinct, their workflow instinct is that I'm just going to print it off and hand it to them. So we have a lot of work to do to get that interoperability that's already there all the way down to the front line and implemented fully. And I would just, highly urge every provider organization to ask yourself, are you doing that in your organization? And if not, why? Why are you allowing people to still fax when they don't have to fax? And just take it off the table as an option, and start getting more of that. And that's the way this works. But I don't want to pretend that there aren't gaps. There are huge gaps. And one of the big issues is the usability of that information as well. That's one of the things that we also hear, is that, well, I get those records, but it's like, all I wanted to know was the prescription, was whether this patient is allergic to penicillin, or what medications are they on, and I have to sift through a virtual version of a 1,000-page record that has a whole bunch of boilerplate note bloat kind of stuff in it, right? So those are the next level challenges I think that we want to be able to solve, is to be able to make that better. But getting to your point now, that doesn't mean that everyone's instinct is to share the information. So how do we overcome that? At one level, we just need to recognize these are businesses, and whether we like it or not, we have got a private sector driven healthcare delivery system, and businesses are going to be businesses. But we also recognize that healthcare is different, and we need to make sure that it's different. So in addition to provide the digital tools, you try to make interoperability as easy and as usable and as friendly as possible, and that's FHIR APIs and TEFCA, everything I'm describing. But we've also learned that we also have to tell people you actually have to do it. And that's where a different set of policies comes into place. One is value-based purchasing, and working with CMS and our partners to have more and more organizations who see it as a business incentive to share information. And my experience in working, in the market was that organizations that went from a typical fee-for-service into value-based purchasing arrangements immediately saw the benefit of interoperability and wanted to share information with other parties, because they now see the value quality, the value cost equation, and they want to be able to share that information. So that's one driver, and that's that's proceeding and sort of according to its trajectory. The other, though, is what the 21st Century Cures Act did is came down a little bit with the hammer, and said we need to require that organizations share information, and that's the so-called information blocking provisions. If I had been there, I would have called it the information sharing provisions, but I couldn't change the name. As much as I did when I came in, I said we should start calling this information sharing. It's like, well, I can't get everyone, people's have information blocking in their head, so I couldn't get over it. But that's a set of policies that are now coming into sort of full implementation. I'll just describe where they are in a second. But that basically says that if you are a provider organization or a certified technology developer, like an EHR developer, or a so-called health information network, you have an obligation to share information with any other authorized party. So not just patients, you have that obligation, and HIPAA right of access always, required that anyway, but it also means with other authorized parties, like another provider who is sharing the treatment of that patient, for example, even if you're competitors. So the ONC information blocking rules, which we put into effect in April 2021, require now that those parties share information with other parties and otherwise be subject to investigation, enforcement, and penalties. Now, one of the challenges that we've had with that policy is that the statute didn't define penalties on providers in particular. It punted in a way and said that the Secretary of Health and Human Services will define appropriate disincentives, as they were called. And we came in, 3 years ago, and none of that had been, sort of defined or spelled out. So we've been working very hard, and we issued a draft rule last fall that defined the framework for what a set of disincentives or penalties on providers who are found to be in violation of the information blocking rules would look like, a framework for that, and the first set of those disincentives. So going back to the question, then people are talking about a disincentive that businesses have to share information. This is saying, well, let's add a disincentive to not sharing the information and see how far that goes to make it now a business requirement on you to share the information, otherwise, be subject to those penalties. So that draft rule is out. We've now taken comments. The comment period is closed, and we anticipate finalizing that rule this year. And then we'll see where that goes, right? I mean, that'll be, that's a part of, the regulatory cycles here are long, but that is a, pretty strong regulatory lever now that we're putting in place to get over just the point that you were talking about.
As I listen to you, I want to bring in the equity dimension, which you mentioned early on, and every person I talk to from HHS references equity as a priority. Now, I want to put this out as a bit of a challenge to you all and let you take it in whatever direction you like. When I listen to you, I get excited about the potential, and it reminds me a lot of the discussions I've had over many years with leaders of integrated systems who just talk about transforming patient care and opportunities for using information in new ways and moving away from piecework. I mean, it's a lovely story to listen to, and for clinicians who are in those settings and environments and want to be in those environments, it can be very empowering. It does feel to me like we run risks of exacerbating inequities between high resource and low resource, or more integrated and less integrated systems. You described the scanning of the printout as a lack of training, which is appropriate, but it may be that the lack of training is because of a lack of investment, a lack of resources, a lack of knowledge, and I worry about sort of forgive the phrase, but sort of the rich getting richer and the poor getting poorer, that the potential of improvement and then business success in a high resource environment could be great, but those who are serving populations reliant more on Medicare and Medicaid with lower payment rates may be unable to do that. And then I think, and I promise I'll end my question momentarily, but I think about, moving into human services where, again, the possibility that a very large, sophisticated provider, housing provider, which has a lot of money in it, could invest in the kind of technologies you mentioned, but someone who's, a domestic violence shelter that's small and doesn't have those kinds of resources is less likely. So help me think about this with an equity lens.
Yeah, I mean, digital divide issues are real. I mean, they are real, and there's no, sort of overnight fix to them, and there's no technology only fix to them as well. I think it's just one thing that we need to recognize, that that technology is not going to be sort of the magic bullet that solves these kinds of issues, but it can certainly. We want to make sure that it helps. And doesn't, add to the problem, I think is, one of the things that we've, tried to focus on for sure. So just, unpacking, some of what you're getting at. I mean, we've tried to, sort of identify where are there's areas, where we have lower adoption, higher adoption, less resourced, sort of parts of our ecosystem, and work with our HHS partners, for example, to try to leverage the authorities that we have and the programs that we have to be able to provide more resources for them to be able to invest in technology. So we just announced just 2 weeks ago, I think, a behavioral health IT initiative that we're working on with SAMHSA, which is $20 million grant program out of SAMHSA, and certainly recognize that $20 million in our country in the healthcare delivery system is a tiny drop in the bucket. But what we're trying to do is say, let's pull every lever we can and jointly say, how do you allow the use of those dollars to be able to support technology that is going to advance their ability to interact in more modern ways with the rest of the healthcare delivery system to allow them to be able to do the kinds of things that they and we want them to be able to do. So that's an ongoing set of things, but that behavioral health IT initiative is just sort of one sort of step toward that. We have on an ongoing basis, and I think this year as well, have budget requests to the Congress and A19s for those who are familiar with those, to try to identify and get dollars for the rest of the healthcare delivery system. The meaningful use program and in high tech, $35 billion in incentives that went to hospitals, went to ambulatory providers that got us to those adoption rates that we have, but it left out lots of the rest of the healthcare delivery system, that continuum that you're pointing to, and that's now we know we're in very difficult budget times, we're in very difficult political times, so that's why we're both making the request to say those are resources that are needed. Let's not pretend that those gaps don't exist, but let's also do everything that we can within the department, pulling all the levers that we can to be able to do that. So there's no great single answer to that, but that's a part of the focus that we have, and certainly aren't trying to gloss over what you point out are real gaps. They are for sure. And part of what we're doing, like for example, just TEFCA, just to give an example, is that in the nationwide networks that are in place today, that do have a lot of interoperability going over them. They've been private sector driven, and one of the things that they haven't been able to tackle is that something like 30% of hospitals aren't connected to any of those networks. And so that's one of the things that we with TEF and public-private participation, or the public side of that participation, want to be able to help to advance, is to say, how do we identify who that 30% is? I'm going to guess that most of those are safety net hospitals in inner city environments, rural hospitals, right? Two category. I mean, not to say that's all there is, but I think that there's going to be a large fraction of those who have just the issues you're talking about, either scarce resources on the technology side, scarce resources on the human capital side, some combination of both. And interoperability is one of the things that is a very high luxury for them in terms of their day-to-day survival and what they're trying to do. So that's one of the areas that, for example, one of the reasons that we've tried to step in with TEFCA to say that shouldn't just be an afterthought or something that we allow to languish as we have, as an industry. We need to now shine a spotlight on it and say, there's a 30% there. There may be levers that we can pull from the federal government that lifts them up and gets them connected to allow them, to be on the path that we want them to be on.
Okay, that's helpful at lots of different levels. I appreciate you responding both sort of at the general level and at the very specific. So I'm not going to get to all of my questions, much less all the questions from the audience, but there are a few I want to get in. You can't have an event today without referring to artificial intelligence. So talk to me about the role of ONC in the administration's consideration of how to respond to the growing use of AI, and just give us a sense of what you all bring to that table.
Yeah, I agree. It wouldn't be a meeting if we didn't talk about AI. It used to be blockchain, and we didn't have a whole lot to say about blockchain. So, but thank goodness we're on something like AI, which I think has tremendous value actually for the healthcare delivery system, for all Americans, and for patients. So we are, first off, as a department, we are AI optimists. I mean, we think there's a tremendous amount of opportunity and benefit here. But let me just tie this discussion of AI for a second, and I promise I will come back specifically to the question, to health equity, because I think there's a segue there that's important for people to recognize. When we first came into the administration, we started, like all the agencies, the staff divs and off divs, presenting to Secretary Becerra on, what it is we do, and in particular on health equity, which is, an administration priority, is certainly a priority of Secretary Becerra and Deputy Secretary Palm. And so the question was, what are health equity dimensions related to health IT, and what can we do with health IT to help to, address some of those things? And one of the things that we were briefing on very early, and this is in the summer of 2021, we started briefing on algorithmic bias, as we were calling it then, and the growing evidence, some of it published in Health Affairs, from Ziad Obermeyer and a number of other sort of researchers who were pointing out the increasing use of algorithms in electronic health record systems and in healthcare delivery overall, payer side, provider side, that were having unintended consequences from a health equity perspective that, was, again, not intentional, but having, unintended consequences that could be fairly profound, as well as safety dimensions and others as well. But our focus was at the time on health equity. And the direction that we got, from the secretary at the time was, we need to look more closely at this. We need to dive into this more because this is coming, right? It's a wave that's coming, and we're sort of able to identify it and flag it now, and gave us direction at ONC to start thinking about what we may be able to do in that. So you fast forward, and ChatGPT erupts onto the scene. 1 million users in 5 minutes, 100 million in 3 months, whatever those numbers are, and that sort of coincided with the work that we had been doing for 2 years, actually, and thinking about algorithmic bias. So what we've done is we issued a set of regulations in December of just 2 months ago, that have a set of regulatory requirements related to creating transparency regarding the use of AI-enabled tools in certified electronic health record systems. So a couple of things to point out there. One is we're very concerned about how can we move forward with sort of setting the first principles, because it's all very early for all of us, right? I mean, talk to Google and Microsoft, it's early for them too, right? No one has special knowledge in this. That's the first thing I'll say. That's very clear to me, and talking to the Congress, talking to all these companies, talking to my federal agency partners, is no one has special knowledge. We're all in the soup here together trying to figure it all out, because it's changing very quickly. But we wanted to say, how do we have sort of an approach that starts us on the path toward what we might think of as responsible AI, which is something we're going to have to learn on together, but that doesn't stifle innovation. Because at the end of the day, we, as I said, we're AI optimists. We believe there's a tremendous amount of opportunity here, and from a health equity dimension as well. So our regulations focus on transparency of those systems, because one of the things that we were hearing from providers more and more was the concern about the black box. It's like, there are black box kinds of technologies in my EHR system. They are giving recommendations. I have no idea where they're coming from. And the developers, by definition, because it's some type of AI model, they themselves don't know why it came up with the answer. And you're hearing providers say, I'd rather use the clinical guideline that that I was given, that maybe it's crude, maybe it's rudimentary, but I at least didn't know where it came from. And I can always, then be held accountable for it. So we're concerned about that as well, the increasing black boxness of what was going on. So anyway, fast forward, our regulations require transparency of AI-enabled tools that are in the certified electronic health record system, and the ability then for a user to be able to determine on their own, based on sort of a nutrition label of that AI-enabled tool that has 31 proposed, it's not proposed, it's actually required now, 31 data elements that would give information about that AI-enabled tool. Where did it come from? What was the original intent? What data set was it used? Was it trained on? What was the patient? What were the demographics and the characteristics of that patient population? Are there any known issues, known risks that have been identified in the market? Have you validated this from a health equity perspective, from a safety perspective? Those are the kinds of information that we think are useful to provider organizations that they determine formularies, they determine a whole bunch of other things, and we think that providing this information then allows them to determine whether it's appropriate to use that AI-enabled tool in their setting. So that's what our regulations require. It's a focus on transparency. Last point I'm going to make, because I know we're going to run out of time, is that our approach from an ONC perspective is very complementary to FDA's regulatory authority in this area. So FDA authority is longstanding related to medical devices. And the way I think of these working together is FDA regulations in this space are kind of a foot wide but a mile deep. So if your device, and there are 700 now devices that are approved as software as a medical device, so AI-enabled tools. If your device sort of qualifies as being a device, and the FDA has very specific sort of definitions of that, and it's going to be commercially marketed, now you go through the FDA process, and it's very very rigorous, and people will go through that and understand. But it just applies to those. ONCs is kind of the transpose of that, where we're a foot deep and a mile wide. So we cover a much broader expanse of what might be AI-enabled tools, but the regulatory approach is purely about transparency. We're not approving anyone's AI-enabled tools. We're not telling a provider organization or Epic or Cerner, you can't or you shouldn't use that tool. All we're saying is provide information about that tool so that people know that it's there, and they can make their own decisions about whether it's appropriate to their patient population.
That's very interesting. I know we'll hear more about this. Well, as we just have a couple of minutes, I'm going to ask you sort of a quick final question. ONC is hitting 20 years. It's hard to believe. I remember when it was formed. I'm the first director. If you, and you've been in this field for a while, so I would ask you, tell me what you think is the greatest success that ONC can look back on these 20 years and say, we were here and now we're here and we should be happy about that. And what's the greatest challenge, unfinished business from those first 20 years?
Sure. Yeah, I mean, I think in some ways it's, the answer is probably the same for both, which is I think that the greatest success we've had is is sort of in that C part of national coordinator. Is that that coordination function I think has over time served the industry. I would argue it has served the industry very well because as hard as it is with implementing electronic health record systems and health IT and standards and all of that. Think about a world where we didn't have that. You would have an incredible array of systems that are wildly disparate, hotspots like Boston, San Francisco, New York, Chicago that have EHR density. And then, I mean, talk about a digital divide, right? You'd have much more of a digital divide than anyone could ever think of. And I would argue that, that ONC certification in particular sets a floor that ties together the healthcare delivery system in ways that it wouldn't otherwise be tied together in a very fragmented system that that is highly fragmented on the supply side, on the demand side. It's unbelievably fragmented, and some of the only things that tie those those are the system together as a system is that that same type of technology, certified electronic health record systems, Medicare and Medicaid, have played that role as well and play that force as well. HIPAA plays that role as well. I think it's part of a portfolio of regulatory approaches that provide the bulwark of of systemness that our system otherwise wouldn't have. So I think that's that as an addition to that portfolio, I think it's just hugely important. I think is one of the successes. I think going forward, one of the things that we haven't spent as much time on as ONC, but since I've been here, we're going to spend a ton of time on it, and we've been already spending a bunch of time on it, is the coordination across federal agencies. So that's a big part of what we do behind the federal wall, and now we've kind of tripled down on that. So in this administration, Secretary Becerra has put into place a policy that we call the Health IT Alignment Policy that requires that all HHS agencies in all of their regulations, policies, and funding base all of that on ONC approved standards for data and interoperability in health IT. So that'll get us greater alignment, across our federal agency partners that allow us to be better citizens in the market so that people aren't feeling like they have to do one thing for FDA, one thing for CDC, one thing for CMS. But it'll also allow our purchasing power and our market presence to, reinforce the things that we want to establish in regulation as well. So I think that's been another, thing that ONC has, played a critical role in is getting that alignment. And I think you're going to see more and more of that in the coming years.
Well, that's so interesting. And it is a reminder that from the outset, the message was this is about coordination. This isn't about doing it or doing it for. It's about facilitating private sector actors to align around what they do. And it sounds like that's still very front and center.
Absolutely.
Well, thank you, Micky, so much for taking the time to talk with me today and for sharing so much thought with the audience. For those of you listening, I do want you to know we have other events on Monday, February 26th, as part of our Journal Club series. Author Daniel Neal at NYU will discuss a paper on housing sensitive health conditions predicting poor health quality, led by our senior editor Laura Tolan. This event was recorded and it will be posted shortly, and we encourage you to share it with colleagues. Similarly, as I noted, we have other spotlights that are recorded, and you can find those. Sign up at healthfairs.org/events to get notification for future events. We do have an insider program, which offers exclusive access to content beyond the journal. You can become a Health Affairs insider also on our website. Again, Dr. Tripathi, thank you for what you're doing and the leadership you've provided, for the insights you gave us today, and for joining us for our policy spotlight. And with that,
thank you so much. Really enjoyed it.
That's great. With that, we'll close it out. We are adjourned.
Okay. Thank you.